The topic for today is childhood urinary tract infections, and I'm Dr. Shenal, Thalgahagoda, the consultant pediatric nephrologist at Peradeniya. My email is there at the end for you to pose any questions you have at the end of this lecture. So let's move on. To introduce you to childhood urinary tract infections, let's start with the definition. So a UTI in childhood can be defined as the presence of more than 10 to the power of 5 colony-forming units per milliliter of urine of a single organism in a properly collected sample from a symptomatic patient. So this definition is extremely important. Each aspect of it is important because everything needs to be fulfilled for you to confirm that it is actually a urinary tract infection. So there should be more than 10 to the power of 5 colony forming units. It should be a single organism, so mixed growths are not valid. It should be a properly collected sample, so bag samples are not valid, and it should be from a symptomatic patient. So you usually do not do urine cultures in a symptomatic patient. So all these aspects are important. The commonest organism identified at culture is Escherichia coli, and this organism accounts for more than 80% of all childhood UTIs. And why is childhood UTI an important infection? This is because it is associated with reflux nephropathy or vesicoureteric reflux, and reflux nephropathy in turn is associated with hypertension and chronic renal failure. Epidemiologically, during one's lifetime, the incidence of childhood UTI, or the risk of getting childhood UTI, has been identified as 1.1 to 1.8% in boys, and it is 3 times more common in girls. However, in the first 3 months of life, as with most infections, UTIs are commoner in boys. The incidence also has been found to be 10 times higher in uncircumcised males, so circumcision is definitely protective against urinary tract infections. What makes one more susceptible to get a UTI? Now, there are several factors here. There can be genital abnormalities like, say, phimosis and phimosis in males and labial adhesions in females. Both these entities predispose to childhood urinary tract infections. There can be other genital abnormalities as well that again predispose to urinary tract infections. Voiding dysfunction and constipation are extremely important. Voiding dysfunction can be pathological or it can be behavioral. Pathological as in patients who have an aerogenic bladder or some sort of other problem with the bladder, but it can be behavioral. This is very common in school-going children because they don't like to empty their bladders or micturate during school hours, so they hold their urine in, and especially in girls, this predisposes to urinary tract infections. So they basically don't void from, say, 6 or 7 in the morning till 3 or 4 in the evening, and that stasis of urine, which is a behavioral issue, can predispose them to urinary tract infections. Constipation is another issue because when one's rectum is full of feces, it pushes up the bladder, and this causes a functional obstruction to the bladder outlet and stasis of urine. Vesicoureteric reflux, which everyone knows is associated with urinary tract infections, and other forms of urinary obstruction, be it PUJ obstruction, VUJ obstruction, or bladder outlet obstruction. Anything that obstructs the flow of urine will predispose one to getting urinary tract infection, and any structural abnormality of the genitourinary tract, for that matter, will predispose a child to urinary tract infections. Let's just touch on vesicoureteric reflux. Now, what is reflux? It's the retrograde passage of urine once it enters the bladder to the upper urinary tract. So usually when the urine empties from the kidneys and goes into the ureters and through the ureters into the bladder, and when the bladder contracts, it does not, in normal people, it does not reflux back, or does not go back into the ureters and the kidneys. But in patients with reflux, there is a problem at the vesicoureteric junction which allows the urine to reflux back. Now this may be primary and secondary. Primary when there is just a problem at the VU junction leading to reflux without any other issue with the bladder, or it may be secondary when there is a bladder outlet obstruction and the pressure builds up, and secondary to the obstruction you get reflux. Or when there is an urogenic bladder, again pressure builds up and the reflux occurs. Now primary vesicoureteric reflux is also important because it is associated with renal dysplasia. So not only is there reflux, these patients' kidneys also may not be normal. They may not have formed normally, and they may not have the normal nephron mass that a normal kidney would have. And the other issue with vesicoureteric reflux is that it is familial, and there is a 30 to 50% chance of recurring in first degree relatives, so much so that in times past, when one child was identified with vesicoureteric reflux, the other children were screened for reflux, and this practice is not valid anymore. And vesicoureteric reflux is classified according to its severity from grades 1 to 5, and now this slide shows you the grades of vesicoureteric reflux. As I mentioned, it increases in severity from grade 1 to grade 5. So in grade 1 you get reflux of urine only up to the up to the lower ureter, and there's no dilatation of the ureter. In grade 2 it refluxes right up to the renal pelvis, but there is no dilatation of the ureter. In grade 3 the reflux goes right up to the renal pelvis, and there is slight dilatation of the ureter as well, but no effacement or no dilatation of the pelvic calyceal system. In grade 4 there is reflux up to the pelvis, severe dilatation of the ureter, tortuosity of the ureter, as well as significant dilatation of the pelvic calyceal system. And in grade 5 there is severe dilatation, severe tortuosity, and complete effacement of the pelvic calyceal system. So these are the degrees of vesicoureteric reflux according to severity, and the types of vesicoureteric reflux according to severity, and obviously the higher grades are associated with much more morbidity. Now this slide shows phimosis. So phimosis is important, as I mentioned, because it is associated with urinary tract infections. So it's basically, phimosis is a non-retractile prepuce. So you just try to retract the prepuce gently, and if you can't see the top of the glans, that phimosis is significant. You don't always need to surgically correct these. You just need to apply hydrocortisone cream, and that in itself gets rid of the problem in a majority of patients. These are labial adhesions. These are very tight labial adhesion in a 3-month-old, where the labiate covers the vaginal orifice. Again, this is usually amenable to treatment with estrogen preparations or estrogen creams, and you just need to rub it at the place of the adhesion, and with time it resolves. So remember, in all patients with urinary tract infections, you need to examine the genitalia and look for phimosis as well as for labial adhesions. And you can have patients with recurrent urinary tract infections because someone has just missed the labial adhesions, and just all you need to do is correct the adhesions, and those recurrent infections will be amenable to just a reduction, or just getting rid of the labial adhesion. So let's move on to clinical features of urinary tract infections. Now, Traditionally, UTIs have been classified as febrile and afebrile UTIs. Afebrile UTIs are synonymous with cystitis, where the infection hasn't gone up to the kidneys, and these patients usually present with dysuria, frequency, urgency, suprapubic pain, and sometimes with incontinence. So they're all basically bladder symptoms, and fever is not a prominent feature in patients with cystitis, or it hardly ever occurs. Patients with febrile UTI or febrile UTI is synonymous with pyelonephritis, and in younger children the symptoms can be very vague, and you need to have a great degree of suspicion to diagnose a urinary tract infection. So these younger children with febrile UTIs can have excessive crying, irritability, vomiting, poor feeding, lethargy. So it can be very vague, the symptoms, as I mentioned. So again, as I mentioned, you need to have a great deal of suspicion to diagnose a UTI. Older children, it is easier because they present with well-known features of urinary tract infection or febrile UTIs or pyelonephritis. So they might have chills and rigors, abdominal pain, loin pain. There may be tenderness when you examine them. There, they also present very frequently with vomiting. So it's everything. The symptoms point to the focus of infection. So what are the investigations you do in a patient suspected of having a urinary tract infection? The simple UFR or the urine analysis is extremely important, and this would show pyuria. We consider pyuria, significant pyuria, as less as more than 5 pus cells per high far field in boys and more than 10 pus cells per high far field in girls. We consider these two values as significant. There's some reports of recent that suggest that more than 5 is significant in either girls or boys. And the urine analysis also will show evidence of bacteriuria or bacteria in the urine. Now, this is also extremely important to note. The urine culture obviously is the gold standard, but remember, to diagnose a UTI, you need to have both the UFR and the urine culture showing evidence of infection. So the urine culture, as I mentioned at the onset of this lecture, is considered a pure growth. A significant culture is considered a pure growth of more than 10 to the power of 5 colony-forming units. There are two other investigations that are available in strip form, and these are important to know because they are coming. We still don't use them routinely in clinical practice in Sri Lanka, but these are coming into practice, and they will be available very soon. So these are leukocyte esterase and nitrites, the testing of leukocyte esterases and nitrites. Basically, they just detect pyuria and bacteriuria. Leukocyte esterase basically detects pyuria or the pus cells in the urine, and nitrites make use of the fact that the majority of E. coli are nitrate splitting organisms that convert nitrates to nitrites, and they detect the nitrites in the urine, and by detecting nitrites you can postulate that there is the presence of E. coli in the urine or nitrate splitting organisms in the urine. So these two tests are available on dipstick form, and they help to diagnose urinary tract infections. But for us, basically, what is available is the simple UFR and urine culture. These are what is routinely practiced in clinical practice in Sri Lanka. Right, moving on to treatment. Obviously, it's with antibiotics, intravenous versus oral. So what is available as oral antibiotics? We have coamoxiclav, we have cefuroxime, we have cefalexin, we have cefixime, which is a third generation oral cephalosporin, and we have the quinolones like ciprofloxacin. Intravenously, we have coamoxiclav, cefuroxime, cefotaxime, and ceftriaxone, ceftazidime, and again ciprofloxacin. So basically, this is what you have. When would you use IV? When would you use oral? Well, there is no actual hard and fast rule. If the child is less than 3 months old and he or she has a febrile UTI, you should start with intravenous antibiotics, and maybe if the child is not capable of taking oral antibiotics at that point, your duration of intravenous antibiotics also would be longer, and some would even advise you to go the entire course with intravenous antibiotics. Older children, if the child is very ill and septic, obviously you're going to start with intravenous antibiotics. If the child cannot take oral antibiotics, child is vomiting or has poor feeding, poor oral intake, and is refusing to take orally, it's important to get the antibiotics in. So there again, till the child is better or the vomiting is settled, you're going to have to start with intravenous antibiotics. The duration of antibiotics for a febrile UTI, remember, is 10 to 14 days. You need to treat these patients for 10 to 14 days. Very often, people treat febrile UTIs for 7 days. In my view, it doesn't work, because very often these patients come back again, or the UTI recurs, and that is not really a recurrence. It's the same infection that has reappeared. So you need to treat them for 10 to 14 days. It's tempting to stop antibiotics early, because usually when you start antibiotics, within 24 to 48 hours, the fever settles and the child is completely well. So most people are tempted to stop antibiotics early. But remember, you need to treat febrile UTIs for 10 to 14 days. For afebrile UTIs or cystitis, 7 days. Suffices. So you can start, even when you start with intravenous antibiotics in older children, once the fever settles and the child is well, you can obviously at that point switch on to oral antibiotics, and the rest of the duration of antibiotics you can continue orally. You don't have to give intravenously for 10 to 14 days. Usually 3 or 4 days of IV antibiotics is sufficient to get the patient well enough. The choice of empiric antibiotics depends on the antibiotic sensitivity pattern of your unit. Now, this is not a difficult thing to do, right? It's not a difficult thing to know. You just need to go look through the urine cultures of the past year and find out which antibiotic the organisms are most sensitive to, and that would be your first choice empiric antibiotics. We go with coamoxiclav at Parathenia, but that would definitely depend on, and would definitely differ from unit to unit. And it's extremely important to avoid nephrotoxic antibiotics. Now, even your international guidelines will let you use aminoglycosides like amikacin and gentamicin, but I have not even put it here because we do not have the facility to monitor the levels of these drugs. So because of this reason, and because there are much safer alternatives, aminoglycosides are best avoided. Now, sometimes you might have a very sick patient and the culture is only sensitive to gentamicin or amikacin. Then by all means you should use that antibiotic, but otherwise, if possible, it's best to avoid aminoglycosides. Moving on to other aspects of management, we currently follow the NICE guidelines of 2017, which is very similar to the guideline of 2007. Now, these guidelines classify childhood UTIs as typical and atypical infections. Now, this classification is needed, or this division into typical and atypical infections is needed, because previously all patients with urinary tract infections underwent quite a significant amount of investigation and intervention, which was basically unnecessary in the vast majority. And this system of classifying them into typical and atypical infections identifies the minority of patients that need extensive investigations, and the majority, which are classified as having typical infections, have just a minimum amount of investigations done to them. So this classification was the major change done in 2007, and this has basically changed the management of childhood UTIs, changed the investigation really of childhood UTIs quite tremendously. So what are the features of an atypical infection? So if your child is very ill and looks septic or having septicemia, well, that is an atypical feature. If there is poor urinary flow or any obstruction to the flow of urine, that is again a feature of atypical infections, because these patients may be having posterior valves. If you can palpate an abdominal mass, if there is a palatable abdominal mass, which is the kidneys, that is an atypical feature. Or if you can palpate the bladder, that again is an atypical feature which denotes bladder outlet obstruction or possibly a neurogenic bladder. If the patient has elevated serum creatinine levels or deranged renal function, a normal patient should not have a rise in creatinine with a urinary tract infection. So if the creatinine levels is raised, that means there has to be some other underlying problem within that patient. And if your patient does not respond to antibiotics within 48 hours, you start antibiotics, the appropriate antibiotic. Remember, it's not, you can't start any antibiotics. If you have started the appropriate antibiotic and the patient has not responded within 48 hours, that again is a feature of an atypical infection, right? And also patients with I mentioned at the onset of this lecture that the majority of infections are caused by Escherichia coli, and these account for more than 80% of infections. So if the infection is a non-E. coli infection, it's caused by other organisms like Pseudomonas and so on, those again are considered atypical organisms, and the likelihood of those patients having structural anomalies is higher. So basically the idea of identifying patients with atypical features is because you take these patients, the ones with atypical features, and you investigate them extensively. But the vast majority who have just typical features, you just do minimal investigations. So what are the investigations you're going to do? Now, these are taken directly from the NICE guideline of 2017, and according to these guidelines, in patients under 6 months of age, if the patient responds well to antibiotics within 48 hours of treatment and thus has no other atypical features, you do not do an ultrasound. You do not do an ultrasound scan in the acute stage. You do only an ultrasound scan within 6 weeks of the infection. So no urgent ultrasound scan is needed. You do only interval ultrasound scan within 6 weeks. Again, if the patient has only typical features, you do not do a DMSA and you do not do an MCUG. Whereas if the patient has atypical features, remember we are talking about patients under 6 months of age. If he has atypical features, you're going to do an ultrasound scan in the acute period, or while the child is in hospital. In the acute period, an acute ultrasound scan is needed to detect any structural anomaly. You do a DMSA scan within 4 to 6 months of the infection, and you also need to do an MCUG where necessary. Now remember, though these guidelines recommend an MCUG in all patients with atypical infections under 6 months of age, the MCUG is usually done on an individual. On an individual patient basis. So you just take an individual case and decide whether you need to do a DMSA, do an MCUG rather, or not. If the child has recurrent urinary tract infections, so if there are repeated infections of the urinary tract, you again need to do an urgent ultrasound scan or an ultrasound scan during the acute infection, as well as a DMSA and an MCUG. Remember, this is for children under 6 months of age. So if even in patients with typical urinary tract infections, if the patient has a structural anomaly on the ultrasound scan, which is done as an interval scan, then you would consider a DMSA and an MCUG, or DMSA or an MCUG. That again depending on what you find on ultrasound scan. So in children older than 6 months and under 3 years of age, or between 6 months and 3 years of age, if the patient responds well to intravenous, to your antibiotics, not intravenous, maybe oral, but if the patient responds well to antibiotics and has no atypical features or has a typical urinary tract infections, according to the NICE guideline, you do not need any investigation. This, however, is not clearly appropriate for our country, because remember, in the United Kingdom, by the time you're born, you have had several anomaly scans. So these patients have had previous ultrasound scans to detect structural anomalies, whereas many of our children do not have an anomaly scan. So in my view, all patients with a febrile urinary tract infection need an ultrasound scan. It need not be urgent, but even here you do need an interval ultrasound scan within 6 weeks if you are having a typical, even if you're having a typical infection and no atypical features. For children between 6 months and 3 months of age, if they have an atypical UTI, again you're going to do an ultrasound scan in the acute stage, and you're going to do a DMSA after 4 to 6 months following the infection. Now, the MCUG in these patients, in this category, atypical infections between 3 months and 6 months, 3 months and 6 years, between 6 months and 3 years of age, you do an MCUG again if there are anomalies on ultrasound scan or on DMSA. So again, on an individual basis, you decide on your MCUG on an individual basis. Recurrent UTI, you do the ultrasound scan as an interval scan, and you do a DMSA MCUG if there are anomalies on ultrasound or DMSA. For children older than 3 years of age, respond well to antibiotics, no atypical features. Again, the NICE guidelines do not recommend any infections, but as I mentioned in the previous slide, for the same reasons, you would do an ultrasound scan in a child with a febrile UTI. So you need an ultrasound scan. It need not be urgent. It can be an interval scan, but you need an ultrasound scan. In children older than 3 years with atypical features, again, only an ultrasound scan during the acute stage is recommended. They do not recommend DMSA or MCUG, and the DMSA and MCUG are recommended only if there are recurrent infections. For recurrent UTI, you do an interval ultrasound scan, and you do a DMSA MCUG only if there are structural anomalies, or the DMSA or the ultrasound scan points to the need of an MCUG, for an MCUG rather. So what is an MCUG, or a micturating cystourethrogram? Some books say avoiding cystourethrogram, or VCUG. Now this is a radiological test that is used to determine anatomical and functional abnormalities of the bladder and the urethra. So what you do is you put a catheter in, you instill a dye, a radiofake dye into the bladder, and you remove the catheter and get the patient to micturate. So when he's micturating, you basically take films, and you can see the reflux, or you can see any urethral or bladder anomalies with the films that you obtain. It is considered the gold standard to diagnose vesicoureteric reflux and posterior urethral valves, which is an obstruction at the posterior urethra level, which is seen in boys. Though it is considered the gold standard to diagnose these two entities, remember, reflux can be missed on MCUG, and it is quite frequently seen in clinical practice. You usually do your MCUG 6 weeks after the acute infection. The reason for this is that during the acute infection, there can be inflammation of the vesicoureteric junction, and this can lead to mild degrees of reflux, false positive reflux that is not actually there, and it is only due to the infection or the inflammation at the vesicoureteric junction. So that's why it's recommended that you wait 6 weeks after the acute infection to do your MCUG. But remember, if you are suspecting a posterior urethral valve, you do not wait 6 weeks to do your MCUG. You need to confirm it as soon as possible, and you need to go for an ablation of the valve to relieve the obstruction. So there, in that instance, you do not wait for 6 weeks to do your MCUG. You do it early, and you detect the valves early, and you ablate them early to get rid of the obstruction. MCUGs are usually done under antibiotic cover, so you basically you start an oral antibiotic the day before the procedure. You continue it on the day of the procedure, and you give it for 1 day on the day following. So on the day following the procedure, so for 3 days, you give a course of antibiotics. That's just to prevent any infection that might be caused during the catheterization process. And radiologists frequently request a negative urine culture as a prerequisite to doing an MCUG, but this is quite debatable. DMSA scan, the DMSA scan is basically done to detect renal scarring. So basically it is radionucleic acid, is a radionuclide scan that basically inject into the patient, and you observe the uptake of this dye from the kidneys, through the kidneys, and with the uptake of the dye from the renal parenchyma, you delineate the renal margins, and it is the gold standard thus to detect renal scarring. It is also helpful to identify ectopic kidneys, and it can be used as a confirmatory test for children with multicystic dysplastic kidney, which is basically a non-functioning kidney. So basically to detect multicystic, the kidney as to define the kidney as a multicystic dysplastic kidney, which is a non-functioning kidney, you can do a DMSA scan. So there you also do get some amount of information about the renal function, and the newer DMSA scans will give you a functional assessment as well. But remember, the Gtpa scan is a better assessment of renal function than the DMSA. So the DMSA is primarily used to diagnose renal scarring. The Gtpa scan is similar. It basically takes up it's similar in the sense that it's a radionuclide test. You inject it into the patient, and the kidney takes it up and excretes it, and through the excretion you obtain a curve, and through that curve you can detect any obstruction. So it is basically, the Gtpa scan is assessed to firstly to assess renal blood flow, and also to detect any obstruction to the flow of urine, be it at the pelvic junction or the vesicular junction. And it is also, as I mentioned in the previous slide, it is the best test to diagnose, the best test we have rather, to assess the differential renal function, or the difference in function between the two sides. You can use some captopril. You can do the captopril Gtpa if you are looking to diagnose renal artery stenosis, because captopril reduces the renal blood flow, and this is more so if you have renal artery stenosis. That's besides this. That's just outside the lecture. So what are the evidence-based recommendations that have come about from these new NICE guidelines? Firstly, asymptomatic positive cultures do not need to be treated. So if your patient is asymptomatic and they come with a culture, you can basically disregard that culture. These cultures are frequently seen in patients with phimosis, where there is a little bit of bacterial colonization, and when the patient micturates, the urine comes through that through the colonized area, and those urine cultures are positive. But if you do a UFR in these patients, very frequently the UFR will be completely normal. So that's why I say the patient needs to be symptomatic, and you need to collectively assess the UFR and the urine culture to diagnose a urinary tract infection. So asymptomatic positive cultures should not be treated, and for that matter, urine culture should not be done in asymptomatic patients, which is why the practice of getting a negative urine culture for MCUG also has been debated. Routine cultures are not recommended. Now remember, previously people did urine cultures at the end of their course of antibiotics to see whether they have cleared cleared the infection, and at one time they did monthly urine cultures in patients with UTI to detect possible occult infections. Now this practice is absolutely unnecessary and should never be done. So you should never do urine cultures in asymptomatic patients, and routine urine cultures, if the patient is not symptomatic, should not be done. Routine circumcision is not necessary, but if your patient has recurrent infections, and especially if there are structural abnormalities, urine circumcision can be considered. But then, as I mentioned, a lot of these patients are the phimosis is amenable to treatment with hydrocortisone. And severe grades of vesicral reflux, remember previously all patients with grade 4 and grade 5 vesicral reflux underwent surgical correction by means of reimplantation of the ureter to get rid of the reflux. But there was a large-scale study comparing the efficacy of these measures, this correction of grade 4 and 5 reflux in reducing the incidence of chronic renal failure and hypertension, and they found that whether you corrected them, whether you corrected the reflux or not by means of reimplantation, the outcome was the same. So this practice of reimplanting refluxing ureters has now been done away with, and reimplantation is considered only if there are troublesome infections which are not amenable to manipulation of prophylactic antibiotics. So remember, we hardly now ever do reimplantation even in grades 4 and 5 reflux. What about antibiotic prophylaxis? Now remember, in times past, all patients with a febrile UTI, or UTI for that matter, were prescribed prophylactic antibiotics until the age of 5 years. So all patients with a UTI got prophylactic antibiotics. Now this practice has again been done away with because they found that whether you give prophylaxis or not, the incidence of renal scarring did not diminish. So now there are very specific recommendations for prophylaxis, and UTI prophylaxis is not recommended in the vast majority of patients. So they should not be routinely prescribed. You can consider giving prophylaxis to patients with recurrent infections because of their troublesome, because these infections are definitely troublesome. So you can consider them in these patients, and you should use urinary antiseptics like nitrofurantoin and nalidixic acid as far as possible, because these antibiotics just sterilize the urine and they don't have systemic effects. Another important entity is this entity called asymptomatic bacteria. Now, asymptomatic bacteria is where some children have bacteria in their urine. This bacteria just lies in the urine. It is not causing any inflammation of the epithelium, and it is basically not causing any problems. It is akin to having some sort of normal flora. It is akin to the normal flora in the gut, not exactly the same, but it is similar to that. So these bacteria are not causing any problems, and you do not need to treat. So and these bacteria are another cause of positive cultures in asymptomatic patients. Right? So again, this entity does not require treatment. So you don't need to treat asymptomatic bacteria. So even if you're getting repeated cultures, which you should not be getting because you're not doing routine cultures, even if you do get, you don't need to treat this entity if the patient is asymptomatic. So asymptomatic bacteria does not require the use of prophylaxis. How do you follow up these patients? Patients with renal scarring and reflux and any structural anomaly for that matter require long-term follow-up, and renal scarring can lead to hypertension, so you need to monitor the blood pressure in these patients. We usually do it every 3 months. Renal functional assessment is also needed from time to time, especially in those with bilateral involvement, and you need to do ultrasound scans periodically, maybe every 1 to 2 years, to to monitor the renal growth, because scarred kidneys can stop growing. So we do ultrasound scans in these patients every 2 years just to see how the kidneys are growing. Further investigations in the form of DTPA, a MAG3 scan, which is again similar but more advanced than the DTPA, and the intravenous urogram are needed for patients with other obstructive lesions. For instance, patients with a patient with a PUJ obstruction or pelvic-ureteric junctional obstruction, you need a DTPA to detect that. And remember that patients with recurrent urinary tract infections are candidates for prophylactic antibiotics. So the only definite indication for prophylactic antibiotics is recurrent urinary tract infections. But if the patient has a structural anomaly and does not have the facility to get treatment early, you can consider prophylactic antibiotics on those patients. So again, for other patients other than those having recurrent UTI, for other patients, prophylactic antibiotics should be used again on an individual patient basis. So in summary, remember that typical urinary tract infections, patients without atypical features need minimum imaging, maybe just an ultrasound scan, without long-term follow-up and without the need for prophylaxis. And remember, the current emphasis is on rapid institution of treatment rather than extensive investigations. So if the parents can be trusted to bring the child into hospital or to seek medical advice as soon as the child becomes symptomatic, then you do not need to use prophylactic antibiotics. You just need to get a UFRN culture sent out and start antibiotics. And if this can be done quickly, you do not need prophylactic antibiotics, even in patients with significant structural anomalies. Now that is extremely important. Atypical UTIs and recurrent UTIs need more advanced imaging with or without prophylaxis. As I mentioned, only those who have recurrent UTIs or those who cannot be trusted to get antibiotics or get medical advice sought early are candidates to receive prophylaxis. And long-term follow-up is needed for children with renal scars and other anomalies of the urinary tract. Thank you.